My name is David and I'm one of the JMOs at Nepean Hospital, and today we'll be discussing diabetes management. We'll be going through 4 cases. The first case will be on outpatient management of type 2 diabetes, focusing on good vascular risk factor control to prevent long-term diabetes complications. We'll be going through the different insulin regimens for type 1 diabetes management, how to identify and treat hypoglycemia, and an overview of management of hyperglycemia and diabetic ketoacidosis. Why is diabetes important? Well, it's very common, affecting around 25% of hospital inpatients and around 6% of Australians. But importantly, it's also associated with serious macrovascular and microvascular complications, some of which have been listed below. Diabetes is associated with at least a 2 times risk of cardiovascular disease, 15 times the risk of non-traumatic lower limb amputation. It's the leading cause of end-stage renal disease and blindness amongst working-age adults, and is associated with longer hospital admissions. So now moving on to our first case. So with all of these cases, I encourage you to please pause the video and have a think about how you would manage each of the patients before continuing the video. Our first case is set in a GP clinic, and we have Mr. Williams, a 55-year-old gentleman with 6 years duration type 2 diabetes. His BMI is 31, supine blood pressure 150/100, and his erect blood pressure is 145/98. He has no history of cardiovascular disease. He's on metformin 2 grams daily and multivitamins. He smokes 15 cigarettes a day. He can't recall his last eye or foot examination, and his bloods are as shown on the screen. His HbA1c is 8.5%, total cholesterol 5.5, LDL 3.2, HDL 0.7, triglycerides 2.6. His eGFR is 80, and his albumin-creatinine ratio is 5.0. So have a think about how you would manage Mr. Williams. In an outpatient setting, it's really important that we have good control over vascular risk factors, as that's how we ultimately prevent long-term diabetes complications. I think when people think about diabetes, they think more about glucose control, but it's very important to think about these other vascular risk factors, which is why an endocrinologist devised the mnemonic GLOBES, which stands for glucose, lipids, obesity, blood pressure, education, emotion, smoking, and screening. In a study, it's been shown that multifactorial intervention significantly reduces the risk of long-term diabetes complications. So this slide shows Mr. Williams' risk of developing cardiovascular disease in the next 5 years. This Australian calculator uses parameters including gender, age, blood pressure, smoking status, lipids, and diabetes status. And we can see here that Mr. Williams is at very high risk of developing cardiovascular disease in the next 5 years, in fact, a 1 in 3 chance. So it's very important that we have very good control over his vascular risk factors. It's important to note that these calculators are used in patients with no prior cardiovascular disease, and any patients who have existing cardiovascular disease are automatically deemed to be at high risk. So based on the SEM, we can see that Mr. Williams' HbA1c is suboptimal at 8.5%. His lipids aren't at target. His BMI is in the obese range. His blood pressure is suboptimal at 150/100. He's a current smoker. His screening is not up to date. And based on his urinary albumin-creatinine ratio, he has microalbuminuria. To manage Mr. Williams and any patient in an outpatient setting for diabetes, I would encourage you to use the mnemonic GLOBES. So if we look at his lipids, His HbA1c is suboptimal, and given that he's at the highest dose of metformin, we would start a second agent. In this case, I would say a DDP4 inhibitor or a SGLT2 inhibitor would be a reasonable option. I'll be going through the pros and cons of each class of the anti-diabetic agent later on in this presentation. Given that he's at high cardiovascular risk, we should also start a statin. It would be reasonable to start a moderate intensity statin such as atorvastatin 10 to 20 milligrams noctate or rosuvastatin 5 to 10 milligrams daily. Moderate intensity statins have been shown to reduce LDL by 30 to 49%. And it's important to note that starting statins is based on the patient's cardiovascular risk using a calculator. Diabetes lipids targets are different to non-diabetic targets and are more stringent because of the high cardiovascular risk, and we aim for total cholesterol less than 4, LDL less than 2, and HDL greater than 1. Mr. Williams' BMI is in the obese range, and based on the guidelines would initially aim for weight loss of 5 to 10% using lifestyle changes. The recommendation is that all patients should have at least 150 minutes of exercise every week spread over a few days, and at least 2 resistance training sessions per week. As you already know, lifestyle changes have multiple benefits as it targets many risk factors, including glucose, lipids, obesity, and blood pressure. Mr. Williams' blood pressure is also suboptimal, and in his case, we should start an ACE inhibitor. The reason why we're starting an ACE inhibitor is because he has microalbuminuria, and that is the first line agent. In a patient without microalbuminuria, other reasonable antihypertensive drugs would be thiazide diuretics and calcium channel blockers. The general target for blood pressure in diabetes patients is 140/90. However, in patients at high cardiovascular risk or who have microalbuminuria, we have a more stringent target of 130/80 if possible. We should have diabetes educator input as well. And given that diabetes, 1/3 of patients with diabetes have distress associated with their disease, we would also recommend using a formal screening tool for diabetes distress. Smoking is one of the strongest vascular risk factors, and a study has shown that over a few years, smoking cessation reduces mortality by 1/3. So in this case, we would strongly counsel the patient about smoking cessation and implement support programs and pharmacotherapies such as nicotine patches to assist the patient. Screening is very important to identify if there's any complications from diabetes to ensure that appropriate treatment is administered. The current guidelines recommend 2 yearly screening for diabetic retinopathy with an optometrist or ophthalmologist, annual clinical foot exams, HbA1c 4 times a year, and annual lipids. In Mr. Williams' case, because we're starting a statin, we'll measure the lipids also 4 weeks post starting the statin and then annually thereafter. And we can see from this slide that if we treat Mr. Williams' risk factors to guideline-based targets, we will significantly reduce his risk from 32% to 9%. This slide goes over HbA1c targets. For most patients, we recommend an HbA1c target of less than 7%, but we do try to personalize it based on the patient's clinical profile. In patients who have short duration type 2 diabetes who have no cardiovascular disease and no hypoglycemia, a more stringent target of 6.5% is reasonable. However, in patients with multiple comorbidities or with limited hypoglycemia awareness, a less stringent target of 8% is reasonable. Over the next few slides, we'll be going through the different the different hypoglycemic agents and the pros and cons of each. Metformin is recommended first line in type 2 diabetes, given that it's known to have mortality benefits. It works by increasing sensitivity to insulin in the peripheries and decreasing hepatic production of glucose. It's quite an effective anti-diabetic agent with an associated HbA1c reduction of around 1%. Its other benefits include that it's weight neutral and it has a low hypo risk. It is associated with gastrointestinal discomfort, so we generally start from a low dose and up titrate, and you can also use slow release formulations. Given the very low risk of lactic acidosis, we withhold this medication if the patient's acutely unwell prior to and 48 hours post-contrast procedures. We dose reduce if eGFR is less than 45 and cease if eGFR is less than 30. Given that metformin impairs gut absorption of vitamin B12, it's also to regularly monitor this. The next class of drugs we're going to talk about are the sulfonylureas, such as gliclazide. And this medication works by acting on the pancreatic beta cells to stimulate insulin secretion. It's a cheap and effective drug with an associated HbA1c reduction of around 1.25%. However, there are two main disadvantages with this medication. Firstly, there's the risk of hypos. So in a patient who has hypos, you probably wouldn't prescribe this medication. It also causes weight gain, and as you probably know, obese high BMI is a risk factor for developing type 2 diabetes, and so this drug wouldn't be the ideal drug in a patient who's already overweight. It's also contraindicated in severe hepatic impairment. So SGLT2 inhibitors, also known as the gliflozins, which include empagliflozin, canagliflozin, and dapagliflozin, work by inhibiting the sodium glucose co-transporter 2 in the kidneys to reduce renal excretion of glucose. This is quite an exciting drug, given that in recent years there have been many large randomized controlled trials that have demonstrated additional cardioprotective and renoprotective properties of this class of medication, which is why in guidelines it is now recommended second line after metformin in patients with existing cardiovascular disease. On a side note, dapagliflozin, which is an SGLT2 inhibitor, has also been shown to have benefits in heart failure in both diabetic and non-diabetic patients, which is quite an exciting finding within the cardiology realm. It has a reasonable HbA1c reduction of 0.7%. Its benefits are that it has low hypo risk, and it's also associated with weight loss, which is a good property. And how it causes weight loss is through the urination of glucose. At 2 years, the estimated weight loss is around 3 kilograms. Because of its properties, I think this would be a good drug to start in Mr. Williams. It is, although, associated with side effects, which include urogenital fungal infections. Given that it is a diuretic, it can cause dehydration and hypotension, and there is the risk of euglycemic DKA, which is why it's withheld in acute serious illness, fasting, and before operations. DDP4 inhibitors, also known as the gliptins, include medications such as sitagliptin and linagliptin. And if we look at the flow chart, this medication works by slowing inactivation of GLP-1, leading to increased glucose-dependent insulin secretion and decreased glucagon release. It has a moderate effect on HbA1c, leading to a 0.75% reduction, and its benefits are that it has a low hyper risk and it's weight neutral. Side effects are generally more rare, although can be associated with gastrointestinal symptoms, nasopharyngitis, and we avoid this medication in pancreatitis. So these medications, the medications on this slide are less commonly prescribed, but it's important to have some sort of idea about these drugs. The first class are the thiazolidinones, also known as the glitazones. And these have fallen out of favor as in trials they've been shown to cause weight gain, increase the risk of fractures, cause edema, and heart failure exacerbation. Alpha glucosidase inhibitors work by reducing gastrointestinal glucose absorption. And they're actually quite popular in China, and it's quite cheap. But it's less popular, but it's not really used in Western countries because of the side effects of diarrhea and flatulence. The reason why it's still popular in China is because the drug's more tolerable and effective in Asians. GLP-1 agonists include medications such as liraglutide and exenatide, and I believe all but one of the medications in this class is an injectable. It works similarly to DDP4 inhibitors by increasing glucose-dependent insulin secretion and decreasing glucagon release. Similar to SGLT2 inhibitors, they also have been shown to have cardiovascular benefit in patients with existing cardiovascular disease. So in patients who have prior known cardiovascular disease, the next agent following metformin should either be a SGLT2 inhibitor or a GLP-1 agonist. It's an effective anti-diabetic agent with an HbA1c reduction of around 1%, and it has the added benefit of causing weight loss. In fact, it's been approved by the FDA for weight loss in non-diabetic patients as well, I believe liraglutide. It also has low hyper risk, although it can be associated with nausea and can rarely cause pancreatitis. This is a summary of the different classes of anti-diabetic agents, and I'll let you read through this in your own time. The next case is about Charlie, who's a 15-year-old male with newly diagnosed type 1 diabetes, for which he's not on any medications. Have a think about the different types of insulin regimens that Charlie could be placed on. So this slide shows the body's natural insulin secretion in a patient without type 1 diabetes. If we look at the blue chart, we can see that throughout the day there's always a basal level of insulin with spikes after meals, with insulin spikes after meals to cover for meals. Given that type 1 diabetes is an autoimmune condition that leads to the destruction of beta cells within the pancreas that secrete insulin, and therefore type 1 diabetics have no insulin secretion, its treatment from a glucose management perspective is to try to mimic the body's natural insulin secretion as closely as possible. We'll now discuss the different types of insulins, which are rapid-acting, short-acting, intermediate-acting, long-acting, and mixed insulins. Rapid-acting and short-acting insulins provide the insulin coverage required for meals. Rapid-acting insulins include NovaRapid and Humalog, and these take 10 to 20 minutes to work, peak between 1 to 3 hours, and last between 2 to 5 hours, and are taken just before, with, or just after food. Short-acting insulins include ActRapid and Humulin S. These take 30 to 60 minutes to work, peak between 1 to 5 hours, and last between 5 to 9 hours, and are taken 15 to 30 minutes before food. Intermediate and long-acting insulins are also known as basal or background insulin, as they provide the basal level of insulin required. Intermediate-acting insulins take 60 to 90 minutes to work, peak between 2 to 12 hours, and last between 12 to 24 hours. They're often mixed with rapid or short-acting insulins to provide mixed insulins. Mixed insulins are usually given within the twice-daily regimen that we'll discuss on the next slide. Long-acting insulins provide longer coverage than the intermediate-acting insulins and include Levemir, Lantus, and Tresiba. They're usually given once a day, although Levemir and Lantus may be given twice a day. Discussing three different types of insulin regimens: basal bolus, twice daily, and insulin pump, although there are other types of insulin regimens less commonly used. Basal bolus is where we provide long-acting insulin such as Lantus or Levemir once a day, which lasts for around 24 hours to provide the baseline level of insulin coverage, to provide that baseline level of insulin. To cover the insulin coverage required for meals, we give rapid-acting insulin such as HbAlc or NovoRapid when the patient's eating. However, this regimen does require 4 injections a day, and in patients who are non-compliant or in children who go to school, a simpler regimen such as the twice-daily regimen may be more appropriate. This is where we provide mixed long and short-acting insulin, such as Novamix 30, twice a day. And while this requires less injections, as we'll see on the next slide, it doesn't provide as good insulin coverage. A relatively newer technology is the insulin pump, and this provides continuous short-acting insulin with bolus doses for meals. This provides the best insulin coverage as it allows more accurate titration of insulin as per the patient's needs. So this slide shows the different insulin regimens and the insulin coverage that each regimen provides. As you can see from the red graph, which shows twice daily mixed insulin, it provides reasonable insulin coverage, but it doesn't cover the lunchtime dose as well as the basal bolus therapy. And therefore, basal bolus therapy is generally preferred over twice daily mixed insulin. There are many new exciting technologies within the realm of diabetes, and we've already discussed insulin pumps. But there's also continuous glucose monitoring, such as the Libre device. This device uses a sensor which is attached to the arm, and every time you swipe the device over the sensor, it gives you an instantaneous blood glucose reading. Traditionally, in order to read blood sugar levels, as you know, you're required to prick your fingertip, and that provides an instantaneous blood sugar level reading. But the advantage of continuous glucose monitoring is firstly less finger pricks, and also it provides many more data points. And as you can see from this slide, with this additional data, it empowers both the patient and the clinician to better tailor treatment according to glucose trends. The following cases will be based more on an inpatient setting. I'll start off by talking about the general blood sugar level targets. For most patients in hospital, we aim for blood sugar levels between 5 and 10. If they have comorbidities, the blood sugar levels can be less stringent with targets of 6 to 12. And in patients with limited life expectancy, such as those with late stage cancer or palliative care patients, it's really more about symptomatic control with blood sugar level targets of 6 to 15. Now onto our third case, which is about Mrs. Jones, a 48-year-old lady with type 1 diabetes who'd been paged for a clinical review for a blood sugar level of 3.1. Have a think about what your management plan would be. So based on the blood sugar level reading, it's clear that she has hypoglycemia, which is defined as blood sugar level of less than 4. If she's able to eat, the way to manage this would be to give 15 grams of fast-acting carbs through fruit juice, soft drink, or jelly beans, followed by slow-acting carbs such as bread and fruit. It's important to note that in hospital, all cordial is sugar-free, so it wouldn't be effective in raising the patient's blood sugar levels. So an option is to add 2 teaspoons of sugar to the cordial. However, if the patient can't eat because they're unconscious or if there's severe hypo, you would give 50 ml of IV glucose 50%. In the case where IV access is unattainable, you would give an intramuscular injection of glucagon 1 milligram. It's important to recheck the blood sugar level after 5 to 15 minutes to ensure that it's risen back to normal range, and if not, to provide further treatment. In hypoglycemic cases, you should also think about the cause, which can range from reduced oral intake to high insulin dose, medication errors, and exercise. It's also important to always have hypos as a differential at the back of your mind, especially if the patient is confused, decreased in cases where there's decreased GCS, arrhythmias, sweating, and in met-cause situations. So now onto our final case, which involves Mr. Kim, a 56-year-old male with type 1 diabetes, who you've been paged for a clinical review for a blood sugar level of 17.5. So take some time to have a think about what your management plan for Mr. Kim would be. So for short-term solutions for hypoglycemia, especially after hours, a good option is a supplementary sliding scale, which should be considered when blood sugar levels are greater than 10. In the table, you can see an example of a supplementary sliding scale. And how it works is based on blood sugar levels before meals. Depending on what the level is, the nurse will administer a certain amount of insulin. So for example, if before dinner Mr. Kim's blood sugar level was 18, then the nurse would generally give 6 units of insulin. However, as you can see in the last 2 columns, it's important to tailor the supplementary sliding scale according to how insulin resistant or sensitive they are. For example, a patient who's obese or who's on glucocorticoids would require more insulin than standard dosages. Given that Mr. Kim is a type 1 diabetic who has a blood sugar level reading of greater than 16, it's also important that we check his ketones. And the following table shows the actions appropriate dependent on the ketone levels. If ketones are greater than 1.5, then DKA is probable and you should notify your endo-reg. If ketones are between 0.6 and 1.5, DKA is possible. You should still notify your endo-reg, reevaluate therapy, and monitor every 2 hours. If ketones are less than 0.6, DKA is unlikely and you should monitor 2 hourly. So I'll now provide an overview of DKA management. And a useful mnemonic I use is the SPIDER mnemonic, which stands for saline, potassium, insulin, dextrose, electrolytes, and review. Given that DKA patients are usually dehydrated, it's important to provide rapid IV rehydration. The next step is to check the patient's potassium levels. And in DKA, total body potassium is low, although the plasma potassium can be low, normal, or high. It's important not to give insulin until the potassium is shown to be in normal or high range, as giving insulin will further lower potassium by driving it into the cells. Therefore, you should check the potassium and provide a potassium infusion as per protocol and make sure that it's normal before giving insulin. With insulin, you would give Act Rapid 50 units in 50 ml normal saline as an infusion to bring down the blood sugar levels. And once BSLs are less than 15, you would commence a dextrose infusion to prevent the patient from hypoing. Throughout management, it's important to monitor electrolytes, in particular sodium, potassium, and bicarbonate, and to monitor for complications of treatment such as hypovolemia and cerebral edema. Many hospitals will send their DKA patients to HDU or ICU, although it can be managed on the wards. Ideally, the patient should be on an ECG monitor and initially have 15 to 30 minute OBS. And you can use the respiratory rate to guide whether there's reduction in acidosis. You should also think about the underlying precipitant for the patient's DKA, which can include infection, insulin cessation, and acute myocardial infarctions. In patients with high blood sugar levels, it's also important to consider hyperosmolar hypoglycemic state, or HHS. This is a life-threatening emergency that affects patients with type 2 diabetes, so will not be applicable to case 4, as case 4 is of a type 1 diabetes patient. But I think that it is important to mention within our presentation. It's associated with high mortality of 20 to 40%. We see patients usually have very high blood sugar levels, i.e. greater than 50. And unlike diabetic ketoacidosis, there's no ketones or acidosis. It is associated with hyperviscosity that can lead to thrombotic complications, and its management in some ways is similar to DKA, as we replace potassium, give IV fluids and IV insulin. For our second last slide, I just wanted to talk about who you should refer to the diabetes team, and this includes all type 1 diabetes patients, pancreatectomies, steroid-induced diabetes, although we haven't really discussed that today, patients who've just started insulin, or patients who have unstable glycemic control. So that concludes my presentation. Thanks very much for listening, and if you have any questions, please email me through the email on the screen. Thank you.